patient is a completely edentulous patient. We can observe the face now. The VD is reduced, the lips collapsed, cheeks collapsed. Patient is not happy with the removable denture. Smile. Photo. You can see the patient might have lost weight because of this denture and issues. If you see the lower ridge is okay, but only the upper anterior it looks very proclaimed and downward. We may have to do some mild plastic. And if you see this occlusal view of maxilla, we can see the resorption pattern. The ridge is supposed to be here. But it resorbed and became like a V-shaped ridge. Here there is severe resorption. So even from the buccal resorption happens. All the buccal bone resorbs. This is the palatal border. Till the palatal border, all the buccal bone is resorbed. And vertically also resorption from crestally. So both vertical direction and the circumferential direction, a lot of resorption is there. So we'll see. The lower ridge is quite even. There is no such curvatures. You will see the sphericity. The surface is in the sphericity. So this kind of edentulous patient, they become a class 3 pattern. Can you see? So this is the maxilla, this is the mandible, almost like a class 3 pattern because the maxilla is slowly resorbed backwards. So upper jaw, buccally bone resorbs, but in the lower jaw, lingually bone resorption happens. So the more the resorption happens, the lower jaw becomes wide, the upper jaw becomes short. So this will create problems during teeth setting. Now we will plan for the lower jaw. So as we see, it is completely radiolucent, more lucent, completely osteoporotic bone. So that will be the main challenge, getting a good stability on it. Since the bone is very soft, better to plan with all on 8. We cannot take risk with all on 6.
Yes.
So better place 2 implants in 4 implants in interforamen, 2 implants in distal mandible, 2 implants. The only question is, where is the nerve? Where is the mandible foramen? It is very difficult to see. Maybe some wide line is we can draw. Here, maybe here. So that is the problem with osteoporotic mandible. It is difficult to see the canal. So how to see?
Clinically, elevation of
Clinically also you can see the mental foramen.
Yes.
But inferior alveolar foramen it is difficult to see. So we will see in the cross section whether it is visible.
Sagittal section, sagittal level.
Yes, sagittal section we can check. So first we will plan for we will first see the mental foramen area, exactly in the mental foramen area. This is the right side. See, the bone is supposed to be like this.
Yes.
This option. So exactly in the mental foramen can we place the implant? We can place the implant. For 8 mm or 10 mm short implant we can place. Minimum diameter 3.5 mm. Even in 5. Even in 5 regions. But of course we are not going to place in 5. We will shift it to easy. Yeah, in the 4. See, in the previous case, the premolar cross section was like this. But here it goes like this. So that is the challenge. Each case is different. Fully it is osteoporotic. Only crestal 2 mm bone is there. Only from that we can get some stability. So if you place a 3.75 implant, crestally that implant will engage the buccal cortex and lingual cortex. That is the only stability you will get. Otherwise, you cannot get any major stability. So 3.75 into 10 mm something we can place. We'll see the cross section. So it is safe from the metal form. So we'll see the 3 to 4 to implant. So this is the midline, this bulge. See the shape of the mandible. If you see, the shape is like this. Okay, it's a kind of pear shape. So minimal diameter implant only we can place. We can do till we touch the lingual cortical outlet and select the length around 11 mm. So what is our plan is using a 3.5 is the minimum diameter implant available. 3.5 into 10 or 11. So another implant in 3.2. Almost similar category. Extremely radio lucent osteoporotic bone. The stability what you get will be very less. So this kind of situation, welding is very essential. Immediately you can split your welds. Otherwise going abutment would be so this implants may. See, the another challenge with the interforaminal area is you cannot get any lingual cortical engagement. Lingually you should not go because it is highly vascular. Lingual perforation should not go. So if the entire bone is good, then it is easy case. But here it is a osteoporotic. You will see the left premolar interforaminal. Yeah, this is the metal foramen area. Can we place implant in this metal foramen area? No. It is not ideal. It's very less ideal. So better place in front of the metal foramen. 3.5 into 11 or 12 or something. So all the 4 implants will be less stable. Right? It's a challenging situation. Now we will see the molar. Now see the molar. Knife edge. There is a concavity here and extremely osteoporotic mandible. This is the myeloid edge. What you can do is you can place implant lingual cortical engagement so that you will get engagement from this
below mandible.
Yes, 1300. That will help us. So place here minimum diameter compressive implant and we can bend it. So this we can try here in the molar area. Lingual cortical engagement is a very essential and important technique. It will save us many times. Because if you place implant like this, you won't get a stability. But if you place like this, you will get support from this bone.
So suppose if you place intramedullary, so with time the implant will fail.
No. It depends on the other implants. If the other implants are good,
okay,
nothing wrong.
Nothing.
Here, why we are going for lingual cortical? Other implants are weak. So at least here we can get some lingual. Another implant in. See here also we could be able to find where is the canal, right? Entirely black. Very rarely we can see such kind of cases. Completely black. So the nerve is hidden inside that black. So there is one way to find the canal. We will try that. We can see the line. This line. This is the lower border. This is the upper border of the canal. So probably this may be the canal. You have to just assume it. So whatever it is, if we place intramedullary, it will be very less length. Otherwise, we have to do again lingual cut. Very minimum diameter, short implant, 3.5 to 8 we can do. Okay, now we will see the right side. Here, canal is somewhat visible, right? This is the canal. Okay. Here, the lingual cortical bone is good, so and it is favorable also, like this. So this is near the second molar. If you see in the second molar, the myloid bridge is becoming more prominent. Near the two. So what are the landmarks? This is the myloid bridge. Okay, this is the deepest depression. This concave deepest depression. So our target area is this one. From here, you have to go like this. That's it. The main thing is, what is this angulation? Sometimes it will be like this. Sometimes this will be like this. So keep your finger and keep it parallel. You will never miss. So even if you can't able to see the canal, if you follow the lingual cortical engagement technique, you will be safer. Because the canal will always be below this depression. Now we will try to find the canal here. Just out of. Now we can see the canal here. This line, this line. That means probably here. This may be the canal. So if we assume that there is a canal, we have to use a 6 mm implant. 6 mm implant. But we won't get much stability. So better place a lingual. So our final plan is to implant distal mandible lingual cortical, 2 implants lingual cortical, anteriorly intramedullary implant placement. Okay. There is a small, the bone is going like this. No? So we will open the flap for this patient. The reason is to see the mental foramen and also to level the small knife edge. Yes. And also to see clearly. So before starting the project, you go through the sequence in your mind and write what are the challenges I may encounter during the procedure. 1, 2, 3, something like that. So what are the challenges we may encounter? Placing incision may be challenging because it is a very thin ridge. The incision may slip. And elevating the flap may be difficult because it is a chronic edentulous. No? The tissues will be thin and may be tethered to the bone. So elevating the flap. And bleeding may not be a problem. It is not an extraction in your case. And getting stability in the anterior, it may be a problem. That is the challenges. And lingual cortical engagement, when you try to bend, it may break because it is already a soft bone. So you have to be prepared for that. These are the challenges.